Welcome, everyone. Thanks for joining us for the second webinar from the AIM Lab and from Learnly on COVID-19. It's part of a series of instructional and informative webinars on this topic about the global pandemic and how it's affecting anesthesia and our anesthesia community, and it's especially targeted for anesthesiologists and our academic anesthesiology viewers. So welcome everyone who's joining us today. The goal of this webinar is to build off of our previous session where we were really fortunate to learn from the expertise of our Italian colleagues. By the way, we did hear recently from Dr. Poletti. I think he said that that there is a faint light appearing now in Italy and that they're doing well, and they have been experiencing fewer admissions to the ICU recently, and some ORs have even reopened. So that's a good update from them. But today, what we want to do is hear some new perspectives from our colleagues in France. And so that's the goal. And again, joining me today is my good colleague, Dr. Bassam Kadry. We're going to share duties as we did last time. And Dr. Kadry will in a moment introduce our esteemed panel of experts, both from France and also some of our anesthesia colleagues here at Stanford. I want to give you a couple housekeeping things first. We learned from our first webinar that the best mechanism for asking questions is our Q&A function. So you may notice that the chat window isn't really functioning because we're directing you to please ask questions by clicking the Q&A button. Cathy Wilkerson, who is part of our AIM Lab and has been amazing along with Duani in organizing this with us, has already populated the Q&A window with some of the questions that you've already asked ahead of time. It'll be my job on this webinar to be your voice and facilitate asking those questions to the panel. So if you have questions, please add them to the Q&A window and we can do upvoting throughout the webinar. I'm going to let my colleague, Dr. Kadry, introduce our panel in just a moment. But before I do that, what I want to do is to remind you about CME. We actually have CME credits available thanks to the CME office and Dr. Daryl Oakes, who were great in turning this around very quickly for us. So if you're viewing live, you can go to stanford.cloud-cme.com/lessons, put in the number 35700, and you can claim 2 CME credits. So we'll leave this slide up for just a moment. And now what I'll do is introduce a framing video. So I'm going to ask our media specialist, Mike Wyatt, in just a moment to play a video for you. Like we did in our Italy webinar, what we want to do is to give you a snapshot into what is happening in France right now with COVID-19. So as of April 15th, there have been a total of 100, as you can see on your screen there, 147,000 cases, 17,000. The numbers are right there. What this report, dated April 7th, does is kind of give you an idea, like it did in Italy, of some of what they're going through in France. And what I want to do is hand off to Mike right now and have him play the video for you, just because he has a better connection to our Stanford internet. So it'll just be a short video, but help kind of frame our discussion today and kind of what our colleagues in France have been facing.
The daily COVID-19 deaths has risen to a record high, with 833 new fatalities reported by the government. France has been in a state of lockdown for the past 21 days, and Health Minister Olivier Véran has said that the fight against the virus is far from over. Erin Agunki has this report.
After 3 weeks of confinement, new numbers in France suggest the measures are working, the curve finally starting to flatten. And while the number of patients admitted to intensive care increased over the past 24 hours, taking the number of patients who have left intensive care units into account, a net total of just 94 remain. It's the lowest figure since the lockdown began, alleviating pressure on French hospitals.
On reprend un peu notre souffle. C'est-à-dire qu'on n'est pas en permanence en train de créer des lits, de faire la chasse, de placer des patients. On arrive à admettre tous les patients un petit peu plus facilement. C'est juste un ralentissement du nombre d'entrées. C'est-à-dire ce qu'il faut bien garder en tête, c'est qu'il n'y a jamais eu autant de patients en réanimation en France de l'histoire de la réanimation.
But the situation remains critical, with healthcare workers calling for caution. Though the worst-hit regions of Île-de-France and the Greater East are starting to see signs of hope, the outbreak could still worsen elsewhere.
Ce n'est pas fini, loin de là. On a peut-être atteint un summum en région parisienne, on ne l'a pas atteint dans d'autres régions de France. Donc les autres régions de France vont être touchées. Et donc on reste avec un mois d'avril qui va être extrêmement difficile.
Taking that reality into account, the French health minister has warned against letting up on the confinement measures.
Ce n'est pas terminé, loin de là. Nous ne sommes pas au bout de l'ascension épidémique. Le chemin reste long et rien n'est fini. Les chiffres que je vous ai présentés il y a quelques minutes le démontrent.
In other countries, seemingly reassuring numbers hit a second wave of infections, a situation France hopes to avoid at all costs.
Thanks for that video, Larry. As far as the agenda today, again, we want to welcome everybody who's attending. We have a great panelist and our colleagues in France. As Dr. Chu explained, please enter all your questions in the Q&A panel in Zoom. We have a team that will be moderating that. The topics we'll be talking about is workforce well-being and hospital capacity management, methods to protect the workforce, infectious disease management, specifically in patients not in the ICU or even in an outpatient setting. Another topic is managing ICU capacity, specifically for creating for surge and also ECMO management. We will hear from a resident who's talking about his perspective as a resident trainee in balancing education and service. Resuscitation techniques that are quite unique to the COVID-19 patients and how they're different from normal sepsis or ARDS patients. Thromboprophylaxis, given that this is a higher risk in these patients, and how to manage that. The immunology, the host immune response to COVID-19 is in context of the cytokine storm problem, and then anesthesia management for these patients. So we have a pretty strong agenda, and we're just going to dive right in. We will try to take Q&A with each section at the end, and there'll be a screen to identify when that will happen. And at that point, Dr. Chu will be moderating those questions. Our first speaker is Caroline Déclas. She will be talking about just the medical affairs in terms of workforce well-being and hospital capacity management. Caroline?
Good morning, everyone. I'm Caroline Déclas, Deputy Director of Medical Affairs and International Relations in Rennes University Hospital. And I'm just going to give you first a quick overview of our hospital capacity. So Rennes University Hospital is has four sites, and it has 1,600 beds and 223 rooms. I'm not going to go through all the figures, but what is interesting for our conference is that we have 48 ICU beds usually, medical, surgical, and cardiothoracic and vascular beds. And right now we managed to plan a crisis plan in order to be able to convert our usual beds into COVID beds dedicated to COVID care. And this plan can make us go up to 100 ICU beds, and more about like 200 medical beds can be dedicated to COVID capacity in our hospital. Regarding the video we just showed, the west of France had not been exposed the same way that the eastern part of France. And we are currently hosting 84 hospitalized patients, which is not a saturation level. Paris and the eastern part of France are saturated, but not our part of France. So we also had the chance to have the time to plan our crisis plan. And our doctors will explain you later during the conference how we managed to plan these different levels. Regarding the workforce well-being and occupational health now, I'm going to explain how we managed. So we focused on reinforce and redeploy the working capacities, prevent and protect the working force, and also support them during the crisis. Regarding reinforcing and redeploying the workforce, it consisted in two things. First, we had to identify the internal resources and their skills to be able to quickly redeploy our internal workforce into the COVID unities. So we had to identify if our working force had already been working into an ICU department before, and if they were able to be quickly redeployed into the new department, especially if we had to face a quick spreading of the epidemic. And then we had to solicit external forces, because obviously if there is a rise into the epidemic, we had to be helped by the external forces. So we solicit private hospital, liberal practitioner, and also retired doctors to be able to reinforce our team. Then we also had, obviously, to prevent and protect our workforce, mostly because they are really exposed to the virus. So we set out some training for the new staff and for redeployed resources, mainly focusing into hygiene and COVID patient care. We organized this training before they were redeployed. And we also have regular intervention into the units. And we also try to identify the overexposed services that as COVID plus staff to make sure they are regularly trained and have information about how to keep the hygienic rules in the unit. We also focused on urgent and semi-urgent activities to make sure we limited the number of people on site and the number of patients too. And we also developed the notion of core team and support team, and allowed some of our staff to stay home during the beginning of the crisis to rest and to be able to come to the hospital later, especially if some of our staffs became ill. And finally, we had to work into bringing support to our working force, internal support through psychological support and occupational health hotline. So our staff were able to call someone every day at any time of the day to make sure they've been properly taken care of if they had been ill. And we also organized the centralization of donation and the distribution of it regarding food donation from different industrial economy, and also regarding the equipment, mask, etc. And finally, especially with the HR directions, we also had to take care of everyday life support regarding childcare support, because the schools were closed. So we had to make sure they would have some solutions. And also regarding transportations and housing facilities, especially for the external working force. And also different other small things, but that helps every day our staff like supermarket dedicated time slots, for example.
So thank you so much, Caroline. I'll hand it over to Dr. Chu. If we have any questions from the audience, this is a great time to go ahead and enter them into the Q&A box. Dr. Chu?
All right, so please go ahead and enter your questions for us about occupational health and well-being. As I'm looking over some of the questions that we have gotten so far related to occupational health, one that I see right now relates to PPE. Is your hospital reusing or decontaminating N95s right now, Caroline?
I'm not going to answer any medical question because I'm not a doctor, obviously. So I think I leave the medical question to our doctors later during the conference.
All right. So let's take any questions on workforce well-being and occupational health. While we wait for those questions to come in, one thing that I think seems to be quite common here is, a lot of psychological stressors. Well, I know you can't speak to medical, but has your hospital developed any comprehensive programs to support the workforce in that regard?
Yeah, we are working with the occupational health team every day. Like every week, we have a meeting with them, and we developed the psychological support hotline, internal hotline, that was given to every working force in the hospital. They can call them, and we are also working currently into a guide that will be given to every workforce too, that will be focusing into some advice, but also into psychological support, and also how to manage the everyday life when they are, for example, into a weekend, and they also want to level down the level of stress, how they can exercise while they are at home, etc. So we are working in the whole comprehensive program to help them at work, but also at home.
Great. Dr. Kadry, do you have any questions to add on here?
No, I think, Caroline, it's a great perspective. I think as we continue the program, if anything comes back, we'll come back and maybe ask you. And again, we have time for Q&A for all the sections at the end. So it's going to move on to the next speaker. The next topic is workforce safety and how to protect the workforce. We have Dr. Juliette Piot and Dr. Pierre Albaladejo. And I will hand over, actually Dr. Piot is working right now and she pre-recorded her section. So Mike, I'll hand it to you so that you could go through this next topic.
Good morning, everybody. My name is Juliette Piot. I'm here to talk about our experience here in Grenoble about the workers' protection and training in simulation. So yes, to begin with, as you may know, in every crisis we can highlight some concerns regarding the healthcare workforce management. You will face for sure rapid changes in almost everything and constant updates in number of beds in your units, number of units opened, night shift or your schedule or childcare, etc. So you have to take it into account to manage workers. It's going to be a stressful time for sure, and something which is more specific to COVID, I think, is it's a life-threatening crisis. To compare with a terrorist attack, for example, you won't die of taking care of people of a terrorist attack, but for the COVID, mostly you won't die of it, of course, but you might be infected just by doing your job, and so then you might infect your family, and that's very stressful for workers and for people working in a hospital generally. So to address these issues and to reinforce workers' confidence and self-competency, we developed a training with 4 axes. We wanted to offer self-protection to people, to offer a tangible training, so mostly using simulation, and to have written and printed procedures directly accessible in they were available directly in the units, so you can use it as you work with a COVID patient. You can find here on the right of the slide some videos from the French anesthesia and the French intensive care societies. We used those videos to help us create our own checklists here in Grenoble. So what we did here, more specifically, is that we set up a simulation scenario with the simulation team, and to address previous discussed issues, how to be protected, how to dress and undress, and for COVID units in ICUs, how to conduct airway management for COVID patients. So first, we prototyped the scenario and tested it directly in the ICUs involved with COVID. We set up the scenario and mannequin in an empty room directly in the ICU, and all the medical and the paramedical staff were able to be trained at the same time. For those ICU, we offer training about how to dress, how to undress, and how to intubate the patient, and how to use the suction device, which is a bit specific for COVID patients. In parallel, we trained some of our nurses who were free at this time in order to increase the number of instructors for the simulation scenario. Because I don't know how it works for you here in the US, but here in France, most of our instructors in simulation are also a physician in the ICU or anesthesiologists. And so during the crisis, they were not able to do both simulation and ICU. So we needed to increase the number of instructors to conduct the training. In a second time, so this part was done during the pre-pandemic phase, I would say. We were very lucky to have time to prepare and to train people, so I would suggest, if you have time, to do so as well. Secondly, during the pandemic phase itself, we offer the same training, but this time in the simulation center in order to free up space in the ICUs. This training was for continuous training, surely, but also for non-medical staff, radiologists, SWAT teams, residents, etc. People were able to join this training using an online predefined schedule. And moreover, the previously trained OR nurses conducted the same training, but in the units, in the non-COVID units, or at least initially non-COVID units, because things may change very quickly, we'll see. And this was done in order to provide self-protection and confidence and training, basic training, to all the healthcare workers here in our hospital, to not forget anybody, and we didn't want to have anybody infected by the virus because of a lack in the training. So yeah, that was our first idea. The training went very well and was very well accepted by teams. Yeah, that's it for me. I'm available for questions if you have. And do not hesitate to reach to the AIM Lab or my colleagues if you have any more questions, and I'll be very pleased to answer. Thank you.
Thank you so much, Juliette. So we have questions. Dr. Pierre Albaladejo is going to be answering questions about this really important topic. It seems like simulation was a good way to get everybody accustomed to the mechanics and the emotional and psychological aspects of workforce safety and protection. So Larry, I'll pass it on to you. Any good questions from the audience?
Well, we're monitoring it. I'll remind our audience again, please enter your questions in the Q&A window. If you come up with questions during these talks, there's also an ability, there should be an ability to click on the thumbs up to upvote questions. And right now we're taking questions on workforce safety and how to protect the workforce. So I'll start with one comment while we wait for some questions to come through. There was an interesting series of viral videos on, I believe it was on Instagram, and I'm not sure if other people have seen it, but the theme or the topic was, there is no emergency during a pandemic. And I wonder, Pierre, if you would comment on that, and if you could comment on the role of simulation in that. But the idea behind these videos, which were made by healthcare educators, is that we should be careful to protect ourselves with PPE before responding to an emergency, because if we endanger ourselves as providers and we become infected because we go to respond to an emergency and we haven't taken the time to don or even doff PPE properly, we can endanger not only ourselves but others. So maybe Pierre, you could comment on this idea of there is no emergency during a pandemic, and maybe comment on the role of simulation in improving protecting the workforce.
Yes, thank you, Larry. So Juliette cannot answer because she is on duty in the ICU, so I will try to answer the questions. Yes, the beginning with the simulation center. In fact, we just stopped all our activities at the simulation center in Grenoble to transform the team of educators on those topics. Dressing, undressing, the PPE management, as Juliette said, intubation, extubation, aspiration, and like Rennes Hospital, Grenoble University Hospital was not under the tsunami like Strasbourg or Paris, so we had time to prepare. And the fact is that there was, we felt, and we are less feeling now, a lot of fear from the healthcare workers about the virus. So we try to help them to understand and to train several times and to cross-check each other to check if they were doing mistakes during the undressing, particularly. The emergency, well, there are emergencies in the ICUs, but in fact, all the nurses are already dressed with part of the PPE equipment. They have the FFP2 and mask and also the glasses, and so they can react quickly. So the question is not the emergency. The question is to be sure that the healthcare providers will not make any mistake. They are all young, less than 50 years old, so they are less prone to have severe COVID-19. But we don't want to. We want to reassure them, and we want them to be sure that we are doing everything to protect them, and this is very important. And the psychological effect of the support, as said the previous speaker, is very important in this pandemic.
Okay, we have some questions coming in. How are healthcare workers being how are healthcare workers being infected from the virus if they're in full gear of PPE and not touching their face prior to hand washing? So I guess this question is that there are some reports of healthcare workers being infected with SARS-CoV-2. Apparently they're wearing full gear of PPE in the clinical setting. Are these cases of community transmission?
Well, in France, I don't know in Strasbourg, but in Grenoble, for example, we do not have any contaminated workers. Perhaps it's a chance, but I think that the real question is the shifts they are doing. We know that they are doing mistakes at the end of the shift. The nurses have a 12-hour shift, and we try to cut all these shifts by breaks to avoid those mistakes to happen. So perhaps is it the training? Perhaps is it because our PPE is effective? We don't know. We guess that all the contaminated workers were in fact contaminated at the very beginning of the crisis, when they were not used to use PPE, and perhaps they were not aware of the risk they were taking.
Okay, I think we have time for one more question. When PAPR, powered air purifier suits, are not available, what PPE do your staff use? And I think you've already said this, but they're asking, what is the number of transmissions that occurred between patients and medical staff?
The type of PPE, the type of equipment we use is very simple. A cap, a full head cap, FFP2 masks, glasses, plastic glasses, gloves, disposable gown with a plastic gown on top. So it's very simple, but in fact, we were anxious about any shortage of any of this equipment. And this was a question, because we had signals and information from the hygiene services that we were going to have shortage. Till now, we do not have any shortage in those equipment, but we know that we have, for example, 10 days of stock of these equipment. So the equipment is simple, and the most important thing is to hand hygiene and to wash hands with hydroalcoholic solutions. And this is very important. Our pharmacy is producing our own hydroalcoholic solutions with the alcohol coming from Chartreuse. I don't know if you know the Chartreuse liqueur, which is just near Grenoble in Voiron. So we had a stock of alcohol to do our own solution to avoid shortage.
Thank you. So just to clarify for our audience, FFP2 masks are equivalent to, in the United States, what we would call an N95 mask. And
Yes.
then you have nothing covering your neck and no face shield. Is that correct?
We use face shields but we didn't have face shields before. We begin to have this equipment, and we are using for intubation, extubation.
Okay. All right. Thank you. Bassam, back to you.
Thank you, Pierre. Next topic is infectious disease. We have an infectious disease specialist, Dr. Pierre Tattevin. He's going to be talking about managing COVID-19 patients actually outside of the intensive care unit, on the wards, and potentially in the community setting. Dr. Pierre?
Do you hear me now?
Yes.
Okay. So hello, everybody. I'm Pierre again. It's a very common name in France. I'm a specialist in infectious disease, and I used to work in ICU until last year when I turned 50, but now I only work in the infectious disease department, so I will mostly talk about the COVID-19 outside of the ICU. So I know the time is short, so I try to put on my slides the most important messages that I think are important from our perspective here in France. So maybe the first one is really a red line, is that we have to be aware that many other diseases are still ongoing in our community, and the COVID-19 outbreaks should by no means be a loss of opportunity for these other diseases. And we have very good signs that there have been some loss of opportunity for some disease. For example, myocardial infarction diagnosis has declined last month in France. And it's probably not because there have been less myocardial infarction, but it's probably because the patient did not come to the hospital to get treated. And the same for active TB, for example, that decreased significantly last month in France. And it's just diagnoses that were not made and that we will probably diagnose too late. So one very important point is that every hospital, every doctor, every health system must implement a system that will still take care of the other emergency, even in the big wave of the COVID-19. So the second basic principles that I think is very important to keep in mind too is that all the studies that have been done everywhere in the world with this outbreak is that more than 85% of patients will just get cured with no medical intervention. And it's very important to keep it in mind when we will be talking about the treatment that you can give to patients. And for example, in France, there has been a big polemic about the benefit of hydroxychloroquine, which is administered to patients with lupus usually, and there have been very bad communication with this drug. And following this, some patients with absolutely no indication for treatment took it with no medical overview. And we have been at least 5 people who died because of taking this drug because they saw at the TV or in the media that it was a good drug for COVID-19. So the second message would be not taking any risk with this disease in most patients. They will be fine just waiting for 1 or 2 weeks that the virus will get cured by itself. And the second point, but this you all know because we would not have a big wave in every country if it was not highly transmissible. So it is highly transmissible, probably not only by the droplets, probably also by contact. So we have to be very effective in terms of infection control and hygiene, but it has been very nicely said by Juliette already. The third message is that the paradigm are changing almost every week. So we have to prepare when we do communication about the COVID-19 that what we are saying now may not be what we will be saying in 2 weeks. So we have to be cautious about the messages, and it has been a big problem in France. So for example, the rules for PPE were quite different at the beginning when we didn't know exactly how it is transmitted. And we used to promote the N95 for any patient by the beginning. And in terms of communication, it's quite complicated when you have to explain a few weeks later that finally you don't need N95 mask for everybody. So we have to be humble about what we know about this epidemic. And it will remain the case probably even in the US a few weeks later because this disease brings a lot of surprise. My fourth message is it's more organizational, but it's something that we have to keep in mind too, is patients should not be moved unnecessarily. And to give you an example, when we had to take care of the first patient, the rule was to have it admitted in a very referral center. So we used to move patients from the peripheral hospital to the tertiary care hospital because it could make sense by that time. We didn't have a lot of patients and we had the resources to move the patient. But after, when the number of patients is too high, and I know it's already the case in all states in the US, just keep the patient where he is, except if there will be some concrete gain for him if he's moved to a referral center where the ICU maybe will be better. But otherwise, it's better to leave the patient where he is when he's diagnosed with COVID-19. And it also applies for the long-term care facility, for example. Most of the patients with COVID-19 in our long-term care facility remained there during their disease, and probably it was beneficial. My fifth messages would be about the day 7, day 10 window. You probably will hear more about that on the immunological talk, but it's true that we saw patients that look fine until day 7, and then they worsen quite fast. Sometimes unexpectedly. They were not old, they were not with a big comorbid condition. So the message here is that you can leave the patient at home with COVID-19 if he has no signs that is bad, but you have to be alert and to change your opinion very fast. If you receive a news from his general practitioner or for the patient himself that is not fine at day 7, day 8, day 9, you have to see him fast and to plan admission in the hospital for any kind of symptoms you can have within this day 7, day 10 window, because it may be a chest pain, it may be a breath, shortness of breath, it may be high fever, but whatever happens in this window is something that you should be alert. And finally, but you probably all know about that, we are changing our opinion many times with this virus, so be ready to do that. Next slide, please. So regarding the anti-infective treatment, I can be fast on that because after 2 months of seeing patients in France, and I exchanged with the sites that saw a lot of patients, like in the eastern part of France or in Paris, and we still have absolutely no clue about what could be the anti-infective treatment that will be efficient for this virus. So I put you there the treatment that has been most evaluated. One was hydroxychloroquine or chloroquine, and that support its use. We know that some patients died because of this. And there is a paper, I put you the reference, it comes from the US, where they could compare the evolution of patients who receive it and comparable patients who did not receive the hydroxychloroquine, and that even suggests that it's worse when you receive hydroxychloroquine than when you don't receive it. So really be cautious and don't apply what we have been doing at the beginning to say it's better to give that than nothing. We even don't know that. Sometimes it's probably better to give nothing. The second drug that has been used because it's interesting in vitro is the lopinavir-ritonavir combination, either alone or associated with immunomodulation, immunostimulation by interferon beta, who has some efficacy on the virus in vitro, both. But regarding lopinavir-ritonavir, you're probably aware that there have been a big randomized trial with 100 patients in each arm that saw no real benefit, even on virological endpoints. It doesn't mean that it's bad, because in this trial they use it very late, but it keeps us cautious. The third drug is remdesivir, that is almost not available in France except for compassionate use in pregnant women. So I have not much to say about that. It's interesting in vitro, and there is one publication about compassionate use, but we really don't know if it works. Same about plasma from convalescent, from patients who were cured from COVID and that can be used and that currently evaluated in a few clinical trials. Regarding the antibacterial treatment, what we have been recommending in France, we have guidelines about that. If it's non-severe and you think it could be community-acquired pneumonia, we give either amoxicillin clavulanic acid when it looks like pneumococcus, and the main clue is when they got a sputum, purulent sputum. Or the second antibiotic that we can give is azithromycin, because there have been some co-infection with Mycoplasma pneumonia, for example. And when they are severe, we have guidelines in France for any kind of severe community-acquired pneumonia that give third-generation cephalosporin plus macrolides to cover also legionellosis. And regarding the management of chronic treatment, the main message is that the patient can keep all their treatment, their chronic treatment, including ACE inhibitors or even immunomodulating agents during the COVID-19 outbreaks. The only caution we have is not to use non-steroidal anti-inflammatory drugs in patients who don't have it by the time of their COVID-19. And my last slide, please, just to show you what is the biggest hope we have in terms of anti-infective treatment. This is the guidelines that have been proposed at the WHO. It's called the Solidarity Clinical Trial. It's a template so that we use the best option in our clinical trials. So it's what they call adaptive clinical trial. It means that if after a few weeks we realize that one of the arm is bad, it will just be stopped and the rest of the trial will go on. And on the other hand, if a new drug appears and look promising, they could add a new arm in the trial. And currently we are trying to enroll as much patient as we can in this trial. So we have 5 arms, the drugs I talked to you about, and 1 arm that is standard of care. And until now we have enrolled 650 patients in France. So it's not a lot compared to the 100,000 patients that we had, but we will have probably result by the end of April that may help us to know what is the best treatment among this list of the most promising anti-infective treatment. And I thank you for your attention.
Thank you, Pierre. What we're going to do is we're actually collecting a lot of really good questions, but we're a little bit behind on time, so we're going to batch process the questions later on. So I'm actually going to go right to the next topic, and then Dr. Chu and the team is going to be going through all the ID related questions, and we'll ask them a few minutes later. So next topic is managing ICU capacity, in particular how to increase capacity by leveraging your pre-op and PACU areas. Dr. Yoann Launey will be speaking about this topic. Thank you. Yoann, it's all you.
Yeah, thank you. Hello, everyone. So I'm Yoann Launey. I'm anesthesiologist and the clinical lead of the surgical critical care unit in Rennes Hospital in France. So we're gonna talk about how we multiply the ICU resources to face this crisis. One of the challenge is to increase the number of ICU beds as the weighted amount of critically ill patient is massive. So we define a tackling plan, including 11 levels, which make our basic ICU beds capacity of 65 going up to 110 ICU beds. So one of the main points is to separate COVID ICU patient from non-COVID ICU patients. And so we have created 2 different zones to avoid any cross-contaminations between our patients. We follow, the second point is we followed a step forward strategy for COVID ICU patients. So that means we defined a single way of entrance for our COVID ICU patient, which was the medical ICU. And we defined another single entrance for non-COVID patients, again, to avoid any cross-contaminations and to answer to the need of ICU for not infected patients. Now, the key point to multiply the ICU resource and to increase the number of beds was to anticipate the deprogrammation of scheduled and non-urgent surgeries. So in this way, we were able to redirect the anesthesiologists and the paramedical staff from the operating room towards the new ICU zone. So we transformed post-anesthesia care units into a new ICUs. And then that was the main way how we increased the number of ICU beds. And so anesthesiologists and again, our healthcare providers usually in operating rooms were able to take care of these ICU patients, mainly for non-COVID ICU patients. And finally, we anticipated another an overwhelming admission of COVID patients. So we created collaboration with our surrounding private hospital, and mainly with our anesthesiologists, senior and residents who were trained in our teaching hospital and who were able to take care of ICU patients at least for ventilation and current ICU disease. So now I can give you a quick overview on how we developed the tackling plan. So please on the next slide, yeah. So here is our basic layout of ICU organization in hospital. So we've got 3 different critical care units: a medical one, a surgical one, and a cardiothoracic surgery critical care unit with a module of 8 beds each, multiple module. And I've represented on the right part of the slides the post-anesthesia critical care unit, with each including 12, 10, and 7 beds, and also the neurosurg ICU, including 6 beds. And we've got on the far part of the right side, the operating room who played a role in our plan. So as the crisis, at the COVID patients, the number of COVID patients increased and the admission, we've decided to create, next slides, yeah, thank you. We've got 2 different entrances, one for COVID patients who entered in the medical ICU first, and we transform each module of 8 beds into COVID ICU beds. And as the inflow of patients increased, we've progressively increased the number of COVID modules. So that means we've created created non-COVID ICU beds in the cardiothoracic critical care unit, and so we protected this zone as non-COVID patients zone. And so we were able, as the inflow of COVID patient increased, we opened progressively new module of ICU beds, COVID ICU beds. So as you see on the slides and on the animation. Specifically, we kept the non-COVID ICU beds module in surgical critical care unit because we decided to keep this patient for mainly for intermittent or continuous dialysis, which was really easier to perform. And as the crisis increased, we've opened more and more COVID units. So here is high dependency beds in the medical ICU, and then we've opened also non-COVID on the other side, non-COVID HDU beds in the orthopedic surgery PICU, and then we were able to increase the number of COVID ICU beds in the surgical critical care unit. So that was the 5th level of the plan. So up to now, we've just reached the level 5, and we didn't get higher. But we've planned, just to give you a brief overview, we can go on with how plan to develop in case of overwhelming COVID ICU admissions. So we've created more and more COVID zone, especially in the operating room, which has been transformed in COVID ICU beds, 4 beds in each rooms. And we have also planned to open post-anesthesia critical care, post-anesthesia care units into COVID ICU beds. So finally, in case of overwhelming patients, COVID patient, we've planned to open also 8 more ICU beds for non-COVID patients in private hospitals. So in the last level of the plan, we were able to free 50 non-COVID ICU beds and to take care of 72 COVID ICU beds. But as I said, we didn't reach that stage, and we just stopped at the level 5. And currently, the number of COVID admission is quite stable, and probably will go down in the next few days. I hope so. So just to sum up, the key point from my point of view are the deprogrammation of scheduled non-urgent surgery, which give us the opportunity to redirect the medical and paramedical staff into the new created ICU zone. The other thing is to separate, to have 2 different pathways for COVID patient and non-COVID patient, especially for ICUs. We move also operative room ventilators into PICU. It's another point that we could discuss later. And if we had extra time before the crisis, I can propose to have more time to prepare a triage zone for COVID and non-COVID patients, just to give time to test the patient and to decide what is the best areas, the best unit to address the patient on COVID zone or non-COVID zone. And last thing is the training of medical and paramed staff. So that's my main points, is to give more and more teaching, especially for dressing and using PPE, as Pierre Albaladejo said earlier. So that's very important to get down the pressure on the healthcare providers. So that's the last point I would say. So I finished. You can see a photo of one of our operating room on the right side of the slides, and we converted it into ICU, but we didn't use it actually. Thank you very much for your attention.
You know, at this point, again, we're going to try to make up a little bit of time. So the questions for this section, let's try to save it towards the end of the series. And I'm going to go to the next topic, specifically, again, about ICU capacity, but also specifically ECMO management. So we have Dr. Nicolas Nesseler. Hand it over to you, Dr. Nicolas.
Hi, everyone. My name is Nicolas Nesseler. I am an intensivist and anesthesiologist. I work in a cardiothoracic ICU in the University Hospital of Rennes. So let's talk about non-COVID ICU. In my hospital, the cardiothoracic ICU is in a separate building than the ER and the surgical and medical ICUs. That's why we decided to keep it as a non-COVID ICU. The usual bed capacity is 17 beds and in my ICU, and 7 new beds were created in the PACU, as you can see on the picture. The ventilation capacity has been increased with anesthesia ventilator. So I want to remind you some basic rules which need to be followed with the anesthesia ventilator. It's not so simple. You need to use high fresh gas flows because to prevent humidity from accumulating in the circuit. So fresh gas flow has to be 1.5 times the minute ventilations. Of course, as with a critical care ventilator, you need an HME filters to maintain an adequate humidity in the lungs. Startup tests need to be performed every 72 hours. And you have to keep in mind that the patient cannot be ventilated with an anesthesia machine during the startup test. So it can be a major limitation, a major issue for the most severe patient, for RDS patient. So you have to think about it before to put the patient under the ventilator. In my hospital, usually we don't sedate patient with inhaled anesthetics during long-term care. So the vaporizer have been removed, as you can see in the picture. Okay, so that's basic rules you have to keep in mind. What about the staff? The nurse staff has been increased by mixing ICU nurses and anesthesia nurses, so they can share their experience, and it is especially useful for managing the anesthesia ventilator. Concerning the OR, we have maintained only the emergency cardiac surgery, so aortic dissection, endocarditis, or emergency CABG. And we have also limited the cardiac transplantation program and the long-term mechanical circulatory support program during this period. We can talk now about ECMO. Next slide, please. So as you know, ECMO is a rescue therapy for, and it concerns only a minority of patients, more severe patients. I can see 2 different types of COVID-19 patients who may benefit of the ECMO support. First, severe RDS patient related to viral pneumonia or to ventilator-associated pneumonia. The second category of patient I can see who can benefit from ECMO is a cardiac failure patient, and 2 main possible causes are myocarditis, which have been described in COVID-19, and pulmonary embolism, which might be very frequent according to the early reports. For the ECMO, one of the big issues is the limited resources, and such as ECMO console or tubing. So you should consider a centralized regulation. And for example, in our area, we have a regional centralization with everyday meeting. And for all these reasons, for example, we made the choice to limit the ECPR program, and it's only now a case-by-case decision. ECMO patients must ideally be managed in high volume expert center with more than 20 cases per year. And of course, in this context, the indication must be carefully evaluated. And we can suggest the EOLIA trial criteria for RDS patients. This paper was published last year. And no, in 2018. And ECMO support should be offered only to patients with a good prognosis with the use of ECMO, and especially in the context of possible shortage of resources. For example, if you have the combination of advanced age, comorbidities, and multi-organ failure, it's probably not a good indication. Finally, at this stage, we don't know really if ECMO support is a good therapy in COVID-19 patients, and we need to improve our knowledge on this therapy. That's why we designed a nationwide study that involves more than 35 centers in France to best characterize which patients have been offered such a therapy so far, and which patients will benefit the most of the technique in terms of outcomes. The study just starts. So far, we know that more than 200 ECMOs have been used in France, but I have no more specific data to share with you. That's all that I wanted to tell you, and thank you for your attention.
Thank you so much, Nicolas. We're just going to make a minor adaptation. The speakers are going to be answering the questions asynchronously in the chat. So please continue to type your questions in the chat, and the answers will be typed live. We're doing this primarily right now to save time and make sure that we could get the live questions batched later. So I'm going to go to the next topic, and Dr. Daniel Gottesman, he's a resident in McGill University. He's going to be talking about his perspective as a resident during this pandemic. Daniel?
Thank you, Dr. Kadry. Yeah, good morning, everyone. Bonsoir tout le monde. So my name is Daniel Gottesman. I'm a fourth-year anesthesia resident here at McGill University in Montreal, Canada. And we'll be shifting gears a little bit just to present a little bit on the medical education resident perspective during these unprecedented times. So just to give a little bit of context, we're in Quebec, which is the province that's hit the most right now with COVID positive cases. The McGill University Health Center, we have 6 teaching sites, and we have close to 1,200 residents and fellows across all the programs. Specific to anesthesiology, it's a 5-year program here in Canada, and we have 30 residents across the different years. And so the first thing I'll say is that there are really no easy answers when it comes to this, how to approach, it's really, we're dealing with unprecedented times, and I don't think there are any guidelines or best practices about how to go about medical education in a pandemic. And I think it has to be individualized to the different departments, to the different residents, and the reality and the context in which you're practicing. And something that I've been struggling with, and I think a lot of my peers are struggling with, is this concept of it. There's this balance between that this kind of represents, hopefully that it's a once in a lifetime, but it really is a learning experience, both from an organizational and logistic perspective of how healthcare systems can respond to a pandemic, but also the medical knowledge that we've heard already a lot from the other speakers, the richness of learning how to deal with critically ill patients. But this is counterbalanced by the personal risk and, putting ourselves in harm's way and the risk of transmitting it to family members and loved ones. So there's kind of this tension that exists. And I think it's important to reflect, even in quote unquote normal times, it's difficult to understand what is a safe learning environment where a learner can feel, empowered to acquire the skills and knowledge they need. But in a high stakes, potentially infectious environment, this becomes much more relevant. And I think as a resident, we often are tasked with kind of wearing 2 hats. We are on the one hand, both healthcare workers and employees of the system, but we're also students and learners at the same time. And I think obviously in a pandemic response, we're being called on more as employees and workers to the front line. But I think it's important not to lose sight of the fact that we're still learners and there's knowledge to acquire. I won't discuss the PPE shortages. I think that's been addressed previously. The redeployment measures, that's something that is a major source of anxiety for all our residents here. So because the manpower needs have been so great, they're about 5 to 6-fold normal in terms of staffing the COVID ICUs, the COVID wards, and all the other medical wards. Our faculty has decided to centralize the redeployment through the resident redeployment hub, which basically maintains a roster of all the available residents who can be redeployed to meet the clinical need. And there's kind of, on the one hand, the anxiety relates to the uncertainty of the if and when and where someone is redeployed. There's also a lot of anxiety related to residents feeling that they may be put in a position where they don't have the competence or the skills required to safely take care of patients. And this is made worse by the fact that there's a fear that there may be inadequate supervision given the strain on resources. I'll briefly mention that the certification exam, so the Royal College of Physicians in Canada has postponed our licensing exam at least until spring of the next academic year. So this has major implications for fellowship opportunities as well as people who've had jobs lined up. And finally, I think this was discussed previously as well, but I think we all know that it's well established that residency is a difficult time period in the best of times. And it's made even worse now, especially when our usual social networks are also experiencing undue amounts of stress. So I think as departments and faculties and even individual staff members kind of in the mentor role, I think there should be an emphasis and an investment on wellness and psychosocial support. And finally, my take-home message is, even if we may not be directly involved, in the difficult airway cases, be it for PPE shortages or personal risk, I think there are still many opportunities to contribute outside of direct clinical work, at least in the anesthesia environment. And just an example, two of my co-residents put together an educational video about the appropriate donning and doffing of PPE with our specific equipment available at our sites. And so this was widely distributed and very well received. So just to emphasize that even if we're missing out on some of the cases, I think there's opportunity to definitely contribute to the overall mission. So with that, thank you, and I'll turn it back over to the moderator.
Thank you so much, Daniel. Again, just as a reminder to the audience, your questions are going to be answered live in the Q&A. They're going to be typed up, so please keep them coming. Our next topic is resuscitation of COVID-19 patients, and in particular sort of unique differences of this patient population. Our speaker is Jean-Marc Tadié. Jean-Marc?
Yep, so thank you for giving me the opportunity to share our ideas and experience with the ICU management of COVID-induced ARDS patients. So my name is Jean-Marc Tadié. I'm the head of the Department of Medicine. I'm used to work in the medical intensive care unit from Rennes Hospital. So first, as you know, there is no evidence-based guidelines to take care or to try to heal these specific patients. But I'm going to try to answer the questions: how is resuscitation different from other patients who are admitted to our ICU with sepsis or ARDS? So around 15% from patients with COVID will be classified as severe patients, which means that there is a respiratory rate above 30 per minute and needs for oxygen supplementation. And then among these patients, like maybe 10% of these patients will be classified as critical, and both patients, severe and critical, will need ICU admissions. So the main point is that ICU admission has to be dependent of the severity of illness and not dependent on the ICU capacity. And that's the first point, because it's very difficult, my point of view, to draw any definitive conclusion from the Chinese or from the experiences from Italy, because in Italy, for instance, ICU capacities has been overwhelmed and by coronavirus patients, and there is no guidelines from this experience that we can take. So for us, because we had time to take care of this patient, respiratory failure from COVID pneumonia should be managed exactly as the same way that you manage a severe community-acquired pneumonia. Then we can go for the next slide, please. And the ventilatory management from this patient, I mean, patient from moderate to severe ARDS, in intubated patients should be managed as recommended, which means using a low tidal volume and try to target plateau pressures below 30 centimeters of water using a PEEP strategy. You can use prone ventilation for at least maybe 12 to 16 hours and use continuous NMDA infusion at least for 48 hours. You can use non-invasive ventilation in COPD patients. That, for me, only for COPD patients. You can use also oxygen therapy using high flow nasal cannula in hypocapnic patients. Not for me, it's kind of dangerous way to try to deliver oxygen to patients who actually are normocapnic or hypercapnic. I think that it's gonna increase your mortality because you have to remind that the high respiratory rates in this kind of patient will dramatically increase lung injury, you know, the concept of self-inflicted lung injury. And as I told you, there is no evidence-based guidelines, but it appears from the experience from Italy that maybe ARDS patients are not typical ARDS. There is a huge dissociation, a huge discrepancy between the preserved lung mechanics with normal compliance and the severity of hypoxemia in this patient. So maybe we should use a lower PEEP level. That's what we do now. The PEEP level maximum is around maybe 10 to 12, but no more. And because we don't, as we saw, we don't have to have a huge impact of the venous return that may induce acute kidney injury. And we also saw that you had a decreased compliance in patients who actually were treated using non-invasive ventilation. So this is a typical management from ARDS patient with ventilatory support. For sepsis, you have to know that maybe roughly 30% of patients after ICU admission will meet the sepsis criteria. The main point is that maybe sepsis is due to acquired infection because these patients are really immunodepressed or immunosuppressed regarding, for instance, the deep lymphopenia, which is going to be persistent. And I will talk about it later, but when taking care of sepsis, usually you have to follow the guidelines using norepinephrine, steroid, and you have to be cautious with your fluid strategy. You have to find the right way to between the conservative strategy over a liberal strategy, because you have to remind that your patients are actually ARDS patients. But what I wanted to show you is that maybe these patients, when we talk about sepsis in COVID patients, are the same patients that septic patients with suffering from deep immunosuppressions, which is going to induce late mortality. And when you have patients who meet shock criteria, you have really to track the super infection. I mean, bacteria, but also aspergillus and maybe virus reactivation such as herpes or CMV. You can move to the next slide. I try to be quick. And as a conclusion, I just want to remind you that maybe there is some kind of typical features in this kind of patients. The story of COVID pneumonia will start at home, then in a ward. And between the 7th or the 10th days, the patient will require so much oxygen that you have to transfer this patient in ICU. And then if we meet the shock criteria, you have to track the nosocomial infection. And there is some kind of particularity in these patients that weaning from mechanical ventilation may be delayed by the encephalopathy. and I invite you to read. There is a nice paper in the New England Journal of Medicine from yesterday. It's a report from the Strasbourg team. It's part of France about COVID-associated encephalopathy in ICU patients. You have also a high frequency of ICU-acquired weakness because you are using sedation for a long time and neuromuscular blockade agents. You have when you try to wean patients from mechanical ventilation, we have sometimes hypoxemia. We're gonna delay it really for a long time the weaning from mechanical ventilation. And be aware that because there is some kind of risk factors such as higher body mass index, maybe your patient's gonna have a post-extubation stridor that's gonna require steroid treatments or tracheotomy. And as I told you, you have to track nosocomial infection to avoid the late mortality in this patient, because as the first report shows us that the mortality of the patient from COVID outbreak will die not within the 2 or 3 first days after ICU admission, but mostly after 2 weeks of hospitalization. I'm done. Thank you.
Thank you so much, Jean-Marc. It's very illuminating and the unique differences that you've highlighted. Again, just a reminder to the audience, the questions are going to be answered typed live by each of the speakers, so keep your questions coming. Thank you so much, and we're going to go on to the next topic. Thromboprophylaxis in COVID-19 patients. This patient population has some unique risk factors, increased risk for thrombosis. So our expert who's going to be speaking about this is Dr. Pierre Albaladejo. Dr. Pierre.
Thank you very much. My name is Pierre Albaladejo. I'm a professor of anesthesia and critical care in Grenoble. So Grenoble is in the Alps mountains. And I will talk about thrombosis and COVID-19. Why do we talk about that? Because there are some evidence and observations that those patients have a severe inflammatory state and a severe hypercoagulable state, as illustrated by high rates of fibrinogen, D-dimers, and CRP, which are also bad prognosis parameters. There has been a pathological study showing pulmonary microvascular thrombosis that may play a role in the ARDS patient. There are 2 very recent papers showing that there are high incidence of thrombotic events, not only pulmonary embolism or deep venous thromboembolism, but also other type of thrombosis, like thrombosis of catheters, venous and arterial catheters, that needs to be removed very frequently, and also filters, clotting for renal replacement, and also observation of clotting of the tubing or oxygenators of the ECMO. We did a quick survey in France and in Strasbourg, Lille, Grenoble, also in Cremona in Italy, and Lausanne and Geneva in Switzerland. We ended up with more than 15% of thrombotic events, symptomatic thrombotic events during the course of the ICU. And also this very intriguing paper saying that it may be beneficial, there may be a beneficial effect of heparin on survival if D-dimers are higher than 3 micrograms per milliliter. The next slide. So two working groups on thrombosis and hemostasis in France decided to give some guidance documents, only suggestions and propositions, because as it was said by Pierre earlier, everything is changing every 2 days. So we decided to focus on 2 major risk factors. The first one is the severity of the disease, split in 3 categories. The patient has no need for oxygen, oxygen therapy, nasal oxygen less than 6 liters per minute, and the patient in the ICU having either high flow nasal oxygen therapy or artificial ventilation, either non-invasive or invasive. The second very important risk factor is the BMI, because it is identified as a risk factor for venous thrombosis, and also the BMI has been associated with the prognosis of COVID-19. And also because the dosage of anticoagulant needs to be adjusted to the BMI or the weight. And this is why we ended up with 3 categories in 3 colors, the yellow, the blue, and the pink. In the yellow boxes, those patients have a relatively low risk for thrombosis because they are not in the ICU, they have no criteria to be in the ICU, and they have no risk factors. And in this patient, we recommend, it's recommended by other guidelines to use low molecular weight heparin or fondaparinux with the standard prophylactic doses. In Europe, it's, for example, for enoxaparin, it's 4,000 units per day. I know that in the North America, it's 3,000 twice a day. If the patient has a BMI higher than 30, with or without other risk factors for thromboembolism, such as cancer or a history of thrombosis, we suggest to use high dose of prophylactic anticoagulant. Those doses are a little bit higher than guidelines on bariatric surgery, for example. So it's in between usual standard prophylactic doses and therapeutic doses of anticoagulant. And there are all those situations where we recommend or suggest the use of full dose anticoagulants. So recommended if there is a symptomatic thrombosis, obviously, with ECMO, but also in situations, if, for example, you need to change the catheter because of clotting, venous or arterial, or if you observe abnormal and frequent clotting of the filters for renal replacement, for example. We added 2 unusual parameters in this table, which are severe inflammatory syndrome or hypercoagulability based on the fibrinogen level. We give an example of fibrinogen higher than 8 grams per liter or D-dimers higher than 3 micrograms per milliliter, where we suggest to use, even without obvious symptomatic thrombosis, curative therapeutic doses of either low molecular weight heparin or unfractionated heparin. And also the monitoring seems to us important because we want to avoid overdose, particularly in the blue part, because we use high doses of prophylactic anticoagulants, and also to have targets to be reached by monitoring this, the anti-10A activity. Anti-10A activity, because ACT is probably not a very good parameter to monitor unfractionated heparin in these very inflammatory patients. So that's it, and this is a guidance document that is on different sites of the different working groups and societies. Thank you for your attention.
Thank you so much, Pierre. Very informative. Again, just as a reminder to everybody, please ask your questions in the Zoom Q&A. They're being answered live by our speakers, so just keep them coming. Some great questions. Next topic, immunology in the host immune response to COVID-19. We have an expert, Dr. Brice Gaudillère. Brice, if you could go ahead, and the floor is yours.
Sure. Thanks, Bassam and Larry, for inviting me. It's a great panel of speakers. I'm an anesthesiologist at Stanford. I'm also I have a research interest in human immunology, and our lab takes a high-dimensional immune profiling approach to understand how the human immune system responds to acute inflammatory challenges. And so I'll talk about the host immune response to the virus today. Before I start, I want to thank Justin Meyerowitz, who's graduating from residency at Stanford, and then also Frank Verdonk, who's a postdoc in the lab, who just came back to France to be an ICU attending at Hôpital Saint-Antoine, and they helped me with these slides. Okay, so the host immune response been getting a lot of press, even in the lay press recently. Here's a great, nice New York Times article with a title that says the patients is betrayed by their own immune system with COVID-19 infection. And so what is this all about? As actually Pierre Tattevin mentioned earlier, it's increasingly recognized that while the first phase of the response to COVID-19 infection is a viral response phase, what is really dramatically leading to severe symptoms in 3 to 10% of the patients is the second phase of the response, which is dominated by the patient's own immune system responding to the virus and leading to really dominating the pathobiology of the severe symptoms associated with lung injury, ARDS, and death in the second phase. So let me briefly, in the next couple of slides, talk about what, at the cellular and molecular level, what is happening in these patients. In a normal viral immune response, or such as in the early phase of the infection, in the case of SARS-CoV-2, the virus infects cells that express high level of ACE2 protein, like pneumocytes in the lungs, in the lung alveoli, also in the kidneys, and as we know. And then these infected cells will start producing receptors, chemokine receptors, and secreting certain cytokines called chemokines, that which role is to attract and recruit the first cell responders, the soldiers of the immune system, the cells of the innate immune system. So those are macrophages, neutrophils, NK cells, and then there are specialized cells called dendritic cells. They're called antigen-presenting cells, and in the context of other cytokines that are antiviral cytokines, like interferon type of cytokines and IL-12, will then go and communicate with the other branch of the immune system, the adaptive branch of the immune system, your lymphocytes, to activate certain types of T cells, predominantly Th1, CD4 T cells, and then cytotoxic CD8 T cells, which are really the major controllers of viral infection. And these cells are very important because being adaptive cells, they respond in an antigen-specific manner. They're recruited back to where the site of infection is, and then recognize specific antigens on the infected cells, kill these cells, kill the viral particles as well. And this is how the infection is being controlled. Now, there's a very important late aspect of the inflammation that happens later on, which is the control of inflammation. And those involve different types of cells, suppressive cells like regulatory T cells, also, and the myeloid-derived suppressor cells in the innate immune system. And these are very important factors that allow the host to control its own inflammation, so that you don't succumb to an overwhelming inflammation. So next slide, please. So this is what happens, when in the early phase, when the body is controlling the infection normally. But then in the context of the late phase of COVID-19 infections, again, 3 to 10% of those patients that have severe symptoms, then there is a dysfunctional host immune response to the virus. And increasingly, it's recognized that maybe one of the predominant factor that maybe initiates this is that there's a profound lymphopenia, and we've heard about this in the other talks, meaning that there's decreased T and B cell counts. Your adaptive immune system is not working, and so the virus is not being able to be controlled very well. So then that leaves the innate immune system not only being the first responder, but being the essential only responder to the viral infection. And so there is a maladaptive then innate immune response with more monocytes, more neutrophils that come into these lungs. They start having a different kind of profile of cytokine response. Next slide. And this is the cytokine storm that everybody talks about, meaning that it's a series of pro-inflammatory cytokines, IL-1, IL-6, TNF-alpha, that drives the recruitment of more of these innate immune cells to the lungs. And then that contributes to the production of hyaline, for example, and the ARDS type of pictures that we can see. Then finally, some of these cytokines, like IL-6, for example, will also inhibit the control of this inflammation. So it would inhibit Treg differentiation, towards pro-inflammatory Th17 type of inflammation. And so you can see that altogether, the host immune response is overwhelming, and also doesn't have a break in the response, leading to profound respiratory symptoms. So because of this mechanism, there's a lot of interest in trying to control this host immune response in different therapeutic strategies. There's, I think, more than 15 trials across the world that are aiming at this, controlling the response. Different type of strategy, anti-IL-6 type of inhibitor like tocilizumab and sarilumab are, there's ongoing clinical trials. They're good or promising responses in non-controlled clinical trials that have been published. And then other type of strategies is to boost the adaptive immune system with interferon type of response, or anti-PD-1, which are to prevent the suppression of these T-cell mediated response. So I want to finish with, maybe what are the big question and maybe a word of caution with the control of the host response in the context of acute inflammation, because we've learned a lot about this type of intervention in the domain of sepsis, where there's been many failed trials in trying to suppress a host immune response in a patient that is severely infected. And I want to show here the data that was just published on the level of IL-6, comparing patients that make it and patients that die. And you see that, yes, it is a predictor for death in the COVID-19 infection, but I also want to point out that there's a huge overlap, right? It's not a great predictor, first of all. And second, you see that there's a lot of patients that die that have somewhat the opposite, that has somewhat a normal IL-6 level. And then on the other hand, there are some patients that will make it with very high IL-6 level. So to finish up, last slide, I think really we're in a position now that we really have to answer the hard questions, which is understanding more precisely what are the mechanisms that are driving or differentiating poor responders to good responders at the cellular and molecular level. We need deep immune profiling studies to really find predictors, better predictors for these high-risk patients, and most importantly, personalize the therapies to the patients that are at high risk, and not treat everybody with the same type of therapy. And thank you very much, and I'll answer questions online.
Brice, thank you very much. That's a very dense and great topic. Again, just as a reminder to the audience, please enter your questions in the Zoom Q&A. Our speakers are answering them asynchronously, and if we have time at the very end, maybe we could do them live. So our next speaker will be talking about the anesthetic management of COVID-19 patients in the operating room. It's Dr. Helene Beloeil. Dr. Helene.
Thank you. And thank you for inviting me to this conference. So my name is Helene Beloeil. I am a professor and in charge of the resident program in anesthesiology, critical care, and perioperative medicine in Rennes, in France. So I'm going to try to be fast because I know we are running late. I'm going to show you the protocols that we put in place, that we printed, that everybody is following, physicians and paramedics in the OR for general anesthesia in this time of a COVID-19 crisis. So this protocol was elaborated following the national guidelines that are available and that were elaborated by our national society. And of course, they were provided with the input of experts on infectious disease like Pierre Tattevin, who talked to us before. So the general strategy for general anesthesia in COVID-19 patient is, first of all, we treat all patients who are suspected of COVID-19 as if they were tested positive for COVID-19. You also have to have in mind in your protocols that you have to deal with the potential risk of lacking anesthesia drugs. You have, of course, to protect the healthcare force, and the critical moments are intubation and mostly extubation.
So for intubation and extubation, we follow these rules. We do intubation and extubation exclusively in the operating room. I don't know how you do it usually in your hospital, but in my hospital, we usually do extubation in post-anesthesia care unit by anesthesiologic nurses. And these days we have changed. We do extubation exclusively in the OR at the end of surgery. When we do intubation and extubation, there's only two persons in the room, the anesthesiologist and the nurse anesthesiologist, that's it. And these two persons are fully equipped with FFP2 or N95 mask. They have gloves, full disposable gowns or suits, glasses or a face shield. So we have face shield in the OR for emergencies, and we have plastic glasses in the OR for scheduled surgeries. And of course, a full hat. And there's one person that is immediately accessible on the outside of the room that can see us, and we can see that person if we have an urgent need. So yes, next slide. For intubation, so we do not ventilate the patient, and we do not use laryngeal mask during this whole time of the crisis of COVID-19. So in order to not ventilate the patient, we use fast-acting muscle relaxant like succinylcholine or rocuronium. This is the muscle relaxant we favor during this time. During the GA, we favor sevoflurane over propofol just to save the stock of propofol because there might be shortage of propofol. And each time you have to do any manipulation, you have to change the position of the patient. For example, you always stop the ventilator before you disconnect the tube to avoid any spreading of any particles in the room. And extubation is the most critical situation because it's when you can spread particles and potentially virus. So we antagonize the muscle relaxants that we've been using. And one more time, we always stop the ventilator before disconnecting the tube. There's only two persons in the room, the anesthesiologist and the nurse anesthetist, fully equipped. And after extubation, we immediately put a surgical mask on the patient. And if the patient needs oxygen at that time, we favor nasal administration, and we put the surgical mask on top of the nasal administration of oxygen. And that's it for me. Thank you.
Thank you so much, Dr. Helene. That's a really helpful and strong insight about just minimizing exposure and only having two individuals in the room upon extubation. So we have, I think that's actually everybody to wrap things up. Again, just as a reminder, we do have Q&A. The speakers are graciously answering those feverishly online. I'm going to hand it over to Larry, but just one question, just for clarification. Helene, you said that you're assuming every patient has COVID-19 and that you're not using LMA on any case for that matter. I just want to get confirmation. Is that true? And then Larry, I'll hand it off to you.
Yes, it's true. We are treating all patients. So we, of course, like Yoann said, we deprogrammed a lot of scheduled surgery, but there's still some scheduled surgery that we have to do, for example, in a cancer patient. So we're still doing some scheduled surgery. And in those scheduled surgery or emergency surgery, we don't use any LMA since the beginning of this crisis. And we are doing the process that I showed you for intubation and extubation. We're following it for every patient. So we are treating everybody as if they were tested positive for COVID-19.
Thank you. Dr. Chu?
Yes, okay, thank you everyone, all of our speakers for the great presentations. We've had so many questions, we haven't been able to keep up, and we wanted to get the information out there for our online viewers. We will be summarizing the questions that have been answered by our speakers. 39 questions so far have been answered online through our Q&A mechanism. We will summarize that for our online viewers who will be watching this afterwards. Let me just ask a few questions following up on our most recent presentation. So, one of the concerns, and we see in our most recent poll that about, I believe, let's see here, 23% of our audience today are anesthesia attending. So I think that it is very relevant, this last presentation, to our audience about the intubation extubation process and reducing the viral load exposure. I wanted to ask a couple of questions related to that. I understand about limiting or eliminating the use of laryngeal mask airways. In China, in Taiwan, in Asia, they have used plastic drapes, placed them on top of the patient. The idea being that they're see-through and that they could trap any aerosolized, in any respiratory tract aerosols that could potentially carry viral particles during the intubation extubation process. Is that something that your hospital is doing or has tried, is the use of plastic drapes over the patient as you're instrumenting the airway?
No, because we don't have that. So no, we're actually not using that because we don't have that kind of equipment. So the only protection we put on, to be fair, we never had in the OR a patient that was hospitalized for COVID-19 and that needed surgery. So all the patients that we dealt with in the OR are patients that are suspected or that we treat like they are COVID-19 positive. And so the only protection that we put on patient is a mask, like just a surgical mask. And but we don't use any specific plastic drape on the patient.
Okay, great, thank you for that. Second question, after, can you speak a little bit about flow rates, both particularly for, you mentioned you use nasal cannulas. Do you have a particular flow rate for that after extubation? Do you try to limit the flow rate of oxygen?
Yes. Why we try to do is that make sure as much as possible that the patient doesn't need any oxygen when we leave the OR, actually. So the vast majority of the time, the patient, after extubation, we wait another few minutes to be sure that the saturation is fine and the patient doesn't need any supplementation in oxygen. And we leave the OR with the patient wearing only the surgical mask. And most of the time, we don't need any supplementation in oxygen.
And could you speak a little bit to your hospital policy regarding monitored anesthesia care, moderate sedation, or regional anesthesia cases? Is this something that you're trying to avoid right now? Or if you do these cases, what aspects or strategies do you use to manage any aerosol control?
So we try to avoid as much as we can monitor anesthesia cases. But if we have to do some, we just ask the patient to wear a mask. And for regional anesthesia, we also ask the patient to wear a mask during all procedures, for the time entering the OR, the time we do the block, and during the surgery, of course, he or she is wearing. And we do the block, especially for the block that are close to the mouth or the nose. So like, for for example, an axillary block, we kind of put a drape between us and the patient to have one more layer of protection, even if, to be honest, I don't know if this is really useful. But so we put one more drape between us and the patient when we do the block.
Okay, great. And can you remind us how many cases of patient to clinician transmission have there been at your hospital?
None that I am aware of. None, I think. None, okay. None, but I don't think we cannot draw. I think we cannot draw any conclusion from this. Are we lucky, or is it because of our protocol, or is it because we are in Brittany, and as it's been said before, the virus has not been circulating a lot in Brittany. We're not in the east of France or in Paris. So so there's been no contamination, but I don't know if we can draw any conclusion.
One additional question relates to mitigating spread to other people in the room. You mentioned that during intubation and extubation, there are two people in the room, the attending and the nurse anesthetist. Do you have a period of time, a washout period, for the room and for the air in the room to exchange, or before additional people are allowed back in?
We make sure that it's us the one who are in the room, who give the signal to the one who are outside so that they can come in, and they only come in when we tell them it's okay. And so we make sure that the patient is on a closed circuit, meaning he's intubated and is on the ventilator, is on the total closed circuit. But our room are under negative pressure, and we didn't take any specific measure to clean out the air.
Okay, great. So with that, thank you very much for all of your answers, and to all of our panelists. There are so many more questions that we can't cover it all in this short period of time, but we actually were managed to answer almost all of them through the online Q&A mechanism. And this does bring us near the end of our CME today. I want to remind those of you tuning in who want to claim CME, you can go to the Stanford website to claim that online. And as for all of our webinars in this series on COVID-19, we will provide an edited recording. We will provide a full transcript, including slides, of this webinar, and we will publish these and make them public. I'm going to hand back to Dr. Kadry for any last remarks here as we're closing the webinar.
Yeah, thank you, Dr. Chu. Actually, there was a couple clinical questions that I think are pretty good. I just wanted to field them. Dr. Helene, one of the questions was talking about the use of LTA on patients during intubation to minimize the chances of cough. Are you doing anything specific to minimize that risk upon extubation?
Minimize the risk of cough, you mean?
Yes, like using lidocaine in the airway, lidocaine spray.
No, we're not actually. No, we're not using anything specific to avoid the patient from coughing. That's why extubation to me is a more dangerous time than intubation. When you use muscle relaxation, intubation is not a very risky time. It's mostly extubation. But no, we don't, and maybe we should use techniques to avoid patient from coughing. But so far we are not.
Okay. We'll wrap up. Just as a reminder to everybody, there is CME credit for this webinar. To actually get access to it, you could follow this. You could go to stanford.cloud-cme.com lessons/lessons and enter 35700, and you could claim credit for attending this session. And again, we want to thank all the guest speakers who were very gracious with their time in preparing for this and attending this. Just as a reminder, we will be doing another webinar. We don't have the date set at this point, but it's about planning to reopen operating rooms and coming up with strategies about how best to stage the reopening process of operating rooms. That will be, again, through Stanford, the Anesthesia Informatics and Media Lab, and the Learnly program. And with that, I'd like to conclude, and thank you very much.
Thank you, everyone.